So in terms of selecting sort of from this menu of therapies that we have, particularly I'm going to focus on biologics and sort of talk about how my mind sort of wraps itself around when I have a patient sitting in front of me. What are sort of the factors? So I'm going to start by saying that I've kind of developed this new strategy where someone has to earn infliximab. That's sort of my new thing, is that infliximab, we believe, because of its weight-based, because we understand the pharmacokinetics, because it's been out for 20 years, because we have a lot of dosing flexibility, it sort of works quickly, and we feel this confidence in its dosing strategies now. And so a hospitalized UC patient because of very bad ulcerative colitis, or even a hospitalized Crohn's patient, the IV administration of infliximab, I think, becomes sort of gold standard for us. And so that's why I say you have to earn it. Or if you have really severe perianal disease as a Crohn's patient, to me, that's the best drug we have for perianal disease that's very extensive in the small bowel. You want to be able to have as much, again, flexibility and dosing. And the difference between some of the self-injectables and the IVs is that the IV, particularly infliximab, is dose based on weight. So that's why we feel a little more confidence in that. But then there's everybody else. People, I'm not saying you're earning Remicade, earning infliximab, it really is on the table. I think patient preference comes into play. So if a patient says, I don't like to inject myself, or I'm nervous, or I have fear or anxiety around injectables, I feel more confident with IV. Or now that we have an oral molecule in UC, it probably is, convenience, we know, is probably number one for a patient, although safety does come into play. But what I tell patients is, their most important thing is treating your disease and understanding what are the risk factors that help me think I would use one therapy over the other. Efficacy, they got approved, so that we assume that they're efficacious, but there is a hierarchy, and that's why I noted you have to earn sort of infliximab. And then also, if a patient is traveling or going to school, doesn't have access to an infusion center, obviously a sub-Q or an oral makes more sense. So I think that disease severity drives my choice, and then patient convenience and safety obviously is very important. But as I noted, the biggest safety issue with these meds is the disease, meaning not effective for the disease and the disease worsening. So there are segments that I would use one over the other. For example, in an older population or advancing age population, safety of vedolizumab, for example, because it is gut directed and it's not sort of systemic in a sense that it's not used for psoriasis or rheumatoid arthritis or uveitis, it's specific to the gut, the safety profile is very nice. And so in patients who are at risk of malignancies or serious infections as you age, that becomes a thing, then we would maybe use vedolizumab. So I'd say if you had to ask me what are my choices, I think so many variables, lifestyle being one, age being another, family history or personal history of malignancy, risk of immunosuppression meaning serious infections, patient preference, oral, sub-Q, IV. A lot of patients want to know how long a drug has been on the market. It does influence their confidence in the safety. Obviously, for a patient, safety is paramount. Patients would rather have pain or diarrhea for not having risk of malignancy. I understand that. But we have to put risk into perspective. And if a patient has risk factors for very complicated or progressive disease, we need to explain that and say we need to bring out this therapy because the biggest risk is the disease progression to complication.